Greetings, it's a pleasure to be back again. Today I'm going to talk about antenatal and maternal health with a focus on the pharmacist's role and the need for involvement. And as you can see from the presentation that I'm having, there's just a slide deck to guide us through the discussion. The key bit about it is let us understand what does maternal health and antenatal health entail first. Then what is our aspiration when we talk about antenatal and maternal health? Then once we look at that dimension, we now need to look at it from the dimension of what are the pharmacist's role and what are the areas we can get involved in, and how is that involvement coming to be? And is that involvement going to help us achieve our aspirations as a community of healthcare service providers, as a nation, humanity? If that is going to be the case, then the question that we need to ask ourselves, these are the areas of involvement, this is how we can get involved, then what are the next steps to actually make that a reality? Because as much as we might talk about what's the possibility, what the potentials that are there, without doing the actual work, we will not realize the successes. And our aspiration is in realizing the successes and seeing the fruits of the work that we're putting in to make that a success. So on that account, then let me get into the discussion. And the major bit for it is in terms of maternal health, what do we talk about when we talk about maternal health care? Maternal health refers to access to healthcare services that is pre-pregnancy, during pregnancy, at childbirth, and after childbirth that will ensure the mother and the child have the best positive health outcomes. And therefore, we know most of the challenges that arise is a result of one, either during the pregnancy, there were complications that the mother did not get the care they need, which might result in preterm delivery, miscarriage, or even abortion, aided or unaided. Those are problems that might arise. If the child gets to the point of delivery, failing to access quality care at the point of delivery, there might be complications. Those complications can result in death of the child or death of the mother. Post-delivery, the experience of the mother during the pregnancy period to the post-delivery session can lead to post-traumatic depression and any other complications that might arise. The child might not be able to actually develop functionally well because of deficiency that might have arisen during the development phase, that is during the pregnancy phase. So if we look at it from that dimension, we see all these possibilities and all these drawbacks, then we need to ask ourselves, where do I, as a pharmacist, come into play? And what does my involvement look like if I come into place in terms of supporting in healthcare delivery, and especially with the focus on antenatal and maternal healthcare service delivery? And on that account, I will be looking at it from what is my role in terms of providing service and care to the mother during her pregnancy, and also the child beyond the pregnancy. And in that case, then when you look about the child, it's about the care we give the mother that might safeguard the health and the well-being of the child. So the first area of involvement would be health education and health promotion. We know that for us to get children, that's the conception phase. And on that account, from conception, one of the key things we have to acknowledge is 30 to 40% of pregnancies are unplanned or unwanted in certain cases. So if 30 to 40% are unwanted or unintended, chances are the lady is conceiving at a point when she didn't expect, she didn't want to, and probably there were risk factors. Probably she was smoking, she was using certain medication that might be harmful to the fetus that is being conceived. It also might be use of drug substances, like let's say alcohol and any other substances of abuse. And if that is the case, then it means these harmful effects of these chemicals and these products might be getting to the child. That will not be safe for the child. And therefore, that is where we need to look at it from preconception care. As a pharmacist, I'm running a pharmacy. Then if patients and the general members of the public get to you, then you need to be able to engage with them. Let's say it's a lady who is in the childbearing age. You need to be able to talk to them and actually help them understand that there is a chance they might get pregnant without intending to, and those are the risks. So what are the services that you can provide for them if they're not intending to get pregnant anytime soon? Contraception services that you can give them. That would be a win for us, because we are reducing the chances of somebody getting the unwanted or unintended pregnancies, which might come with their own complication, especially when you talk about cases that we're seeing with children, with people ladies less than 18 years of age, conceiving and getting pregnant actually. Yes, and delivering kids. There is a child giving birth to a child, and it might be because of sexual advances by elderly people, which needs to be reported as a gender-based issue, which needs to be addressed as well. But on the other end, when we look at it, let's say, for example, we're having sexual relationship among their peers and all, it isn't right in the sense that it's not right for them to get pregnant at that age because they're children. So how can we help them get contraceptive services as early as possible to protect them from getting unwanted and unintended children at that age? So that is your first role. When we talk about it in health education and health promotion, are you able to talk that is beyond the conception, the preconception phase, into the someone who actually wants to conceive? Can you give them guidance on conception, how they need to take care of themselves as if they're planning to conceive and get pregnant? Then when they get pregnant, we know the trimesters of pregnancy, the first 3 months, second 3 months, and third 3 months. What are the developmental milestones in the growth of the fetus in the baby or the baby in the woman? How do this mother or the husband have to conduct themselves? What can they take? What can't they take? Which medicines can they use? Which ones can they use? How do they need to take care of their processes and actually engage with the healthcare service provider so that they derive optimal value out of that? That is the health education and the health promotion. We need to encourage, let's say, for example, activity for the mother, activity for the woman as it is, so that they are able to be actively engaged, also helping in the development of the child. So that education, that information session that you're giving them information and guiding them to be able to know what are they calculate their pregnancy term, so that they're able to go to a hospital before delivery in a right time, rather than having to wait longer and actually having distress at the point of delivery or even delivering outside of a health facility. We know the implications of this, and we need to ensure that we're making it accessible and available for them when they need it. Two, we need to look at it from a preconception care when you're looking about all the other areas of contraception and all that. We also need to know, are you consuming alcohol? Yes, yet you intend to get pregnant. What are the implications of alcohol consumption to a person, a woman in that case, who is intending to conceive? All those impacts will be to the child, because we see areas where we have developmental milestones being a challenge, the child having low brain capacity, brain size, and even the cognitive senses development would be impacted. So if we can be able to educate patients before they conceive and they know how to go about it, that would be a win for us from a pharmacist perspective. And the reason as we see it from a pharmacist perspective is you are at the community pharmacy level or at the hospital level where these people are coming through your desk. And if they might come, probably they were just consulted for and actually offered care in a hospital setting, let's say from a clinician or a physician, based on the clinical need that they presented. Contraceptive use or maternal pregnancy or anything might not have been discussed. And if it wasn't discussed and they come to you, that is the point where you need to engage, because you're the person giving them the medicines. Probably you're giving them a medicine that might affect the pregnancy they have or might affect their pregnancy planning. For example, somebody is intending to get pregnant and there's a particular medicine, then you need to know, is it right for them or is it not right for them? And that takes us to the next phase where we talk about medication management. You need to be able to see which medicines is somebody taking, whether they're pregnant or not pregnant, provided they are women in their childbearing age, and what are the risks in terms of pregnancy, development, and delivery. If you find there are any anomalies, any challenges in terms of the medicine, the risk categories from A to X, then you need to make a rational decision, and that should be informed by science and evidence that, I either change the medication, and it might actually be more critical for patients who are living with chronic conditions, diabetes, hypertension, cardiovascular complications, anything, whatever it is, and this patient asthma treatment and all that. If any patient has such kind of challenges, then you need to be able to understand these probable products they're using might affect the development of the child. Is it able to substitute them? Is it able to tap at the dose and see how to coordinate that care, that pregnancy for them? Or is it recommended that they would delay their conception for a period of time as they're using that medication until they stabilize, after which then they're now able to conceive and actually be assured that the development of the child will not be impacted as much. Those are areas that we need to look at. And if we're able to do that, that would be a win in terms of medication management. Then once they've conceived, let's say, for example, you're in a pharmacy and somebody's coming to you at the pharmacy. This mother, this woman is already pregnant, yes. And oftentimes they buy medication. And if they're buying medication, you need to ask yourself, is it the right medicine for them? It's not that actually, at least in any pregnancy, at least one or every woman will have used an over-the-counter medication in the first 3 months of pregnancy. So the question is, which products are you giving them at that point in time? Because most of the time they'll buy them from the pharmacy. So if you know that this is the probability that they might be coming for medication, you need to be able to counsel them, get to know more about their reproductive health and all that. Then you're able to advise them better so that they avoid the probable risks. And we have to know that the first trimester of pregnancy is the most critical. That is the developmental phase where the organogenesis, the formation of the body organs are happening. If there are any compromise at that point, you are affecting the fetus that is going to develop. So are you going to take responsibility for that and ensure you support the mother in her journey? That is a critical bit that we need to take care of. And we need to ensure it happens the best way it needs to be. Critical for us. Medication management, and even at the point when after delivery and all that, you need to ensure that the medicines are safe for the mother and also safe for the child. And that is where we now talk about it after delivery. We know that breast milk is one of the recommended approaches to ensure nutritional value and nutritional health of the child is maintained. But at the same time, when the mother is taking some medications, due to the metabolic processes, some of them will be excreted in the breast milk. And if these medicines are not safe for the mother, then it's going to affect the child. It's not safe for the child. If they excreted in the breast milk, during lactation, breastfeeding, that is, the child intakes some of these medicines. If it's not safe for them, you'll be affecting that child. So can you even use that information to advise the patient? If you're taking your medicine, let's say it's a twice daily medication, in the morning and in the evening, pharmacokinetic, at what point do we have the lowest level of the medicine being excreted in breast milk? Probably before the next dose. So it's recommended breastfeed before you take your medication. And even if possible, you can pump, that is the pumping of breast milk. You can pump and reserve sufficient quantities that can feed the child for the next 4 to 6 hours. And if that is possible, you're reducing the exposure of the child to these medicines, but the mother is still getting value in the uptake of their medication. Therefore, they're able to achieve positive health outcomes. So as a pharmacist, you need to have this dimension, these perspectives, and actually see the continuum of life of the patient that you're serving. And if you're able to, that would be a win for us. The other thing is in supplements and nutritional aid. When we talk about supplements, during pregnancy, the physiological processes in the body of a woman will change. And that is, for example, increase in plasma volume. And therefore, that is where the blood levels might be affected because of they might get anemic or such. And therefore, you need to provide supplements. And oftentimes when you see in the public institutions, we have ferrous sulfate supplements, which are supposed to help them boost their blood production, red blood cells majorly. So are we able to do that? Are we able to advise them based on their needs and even if necessary, do a blood profile for them? Folic acid. Normally we know there's need for folic supplements in pregnancy because of the recommended dosing, the recommended intake. Probably if their nutritional supplies does not contain the sufficient quantities, you need to be able to advise them on that. And if you're able to, that would be a win for the patient because you are helping them be in their optimal physiological capacity and also to help in nutritional provision for the newborn or the developing fetus in the bodies. So that is key. Iron, folic acid, are you able to recommend or do you know at what levels are there? What are their nutritional needs? What are their required levels? Are they meeting them from food or not? If they're not, are you able to supplement? Calcium, development of the bones and actually the cartilaginous tissues of the baby will be dependent on calcium supplies. Calcium driven from the mother in terms of the nutritional value. So are you able to actually supplement for that? Vitamin D, whatever nutrients that are needed for the development of the child, from a pharmacist perspective, you need to see, are they available for the mother? And if they're available, then they would be transferred to the child. And if not possible, then can you offer supplements? And that is where you need to apply your skills again and deliver that, ensure the patient or her mother has optimal nutritional supplements. And that is where you can also collaborate with, let's say, for example, dietitians, nutritionists, and all that to ensure the mother or the patient has optimal value. Immunization. There are different immunization services that we normally have. And oftentimes when people talk about immunization, we're talking about the immunization program for children. Yes, that is good. We need to have that in place. But there are immunizations, actually vaccinations that are recommended in pregnancy. For example, we can talk about the tetanus toxoid vaccine, because we know there's the risk that is inherent with pregnancy and even the point of delivery, and they need to protect the mother by vaccination. So oftentimes it's noted that most women don't even get these vaccinations. It's not that they don't want to, probably they don't even know that it's a recommended procedure. And as a pharmacist, over COVID period, we've seen there's a growing knowledge and awareness that pharmacists can deliver vaccines and vaccination services. So can you position yourself to do that? And if you're able to position yourself to offer those services, offer the counseling and the health education that I mentioned about, but at the same time, when you know now this person is pregnant, recommend that you can either vaccinate them or refer them to a vaccination service station so that they get the vaccines. And in that case, you'll be helping them. And it's noted that actually, even for DPT, diphtheria, pertussis, yes, and tetanus, the toxoid vaccinations and related, It's noted that pertussis is one of the causes of death in more than children. Let's say, for example, children less than 3 months, 60% of their deaths are associated with pertussis in certain cases. Mostly this is data that is driven from the US. And on that account, then you need to ask yourself, are you able to ensure they are vaccinated early? Let's say the mother is vaccinated early so that that immunity is conferred to the child by the generation of the antibodies in the mother. So those are some of the things that you need to look at: vaccination, immunization, and you also need to see what other immunizations are available. For example, we normally have influenza vaccine. Is it recommended for the child? Yes, it's safe for pregnancy, and you need to be able to mark that and actually offer it if they need it. If it's not relevant, it's not necessary, you need to avoid. And when you talk about medication management and also vaccination, we need to say that in pregnancy, we recommend reducing the number of medications that a mother is on as much as possible. You're not supposed to give any medication just because of it. You need to give it if really, really necessary. And that is the case where you need to apply your pharmacist and medicines expertise knowledge to ensure you're serving your patient the best way possible. The other bit is in terms of pharmacovigilance reporting. We know that clinical trials are not done in pregnant women and children, very young children. And therefore, it means if you're going to use such medications on a patient, then it needs to be justified by need. But at the same time, during that use, you're able to generate evidence on the impact of that product, for example, the safety, efficacy, and even the side effects profile that can be generated. If the patient reports side effects that are noting with the use of one medicine, as a pharmacist, you're the medicines expert, you're able to document that and report it to the regulatory agencies. For example, in a Kenyan context, Pharmacy and Poisons Board. On another context, you can see you're reporting it to the pharmaceutical manufacturer of that drug so that they're able to investigate and give updates on the literature so that the next patient doesn't have to use the same medicine, provided that new data has been generated. Because if we don't generate that data, we are going to impact more lives. And that is where we need to play our role as the pharmacovigilance experts in that space, ensuring we are improving antenatal and maternal health services. Referral services, we know we have obstetric and gynecologists, we have specialists, let's say, for example, like lactation specialists and anywhere. So as you're managing a patient, are you able to refer them to the person who is going to give them the services they need? And that is where we can now have structured collaborative engagement. And we would look at it from our sense of collaborative practice agreements, where you agree with one of the gynecologists and actually see if patients come to me and I assess them from the elective services that I need to offer, if there's additional need for further support, then I would be referring them to you as a specialist to offer the additional services. It means these people have access to quality care, and there's a continuum of care because there's documentation and reporting. That way, we have a referral pathway that is seamless and structured. That helps us ensure optimal care for the patients and the people that we're serving. Other than that, the other bit that is key now when we look at all those services, how do we make these fit? How do we make these become a reality in our service delivery? And on that account, the thing that we need to acknowledge is there has to be willingness and adoption by pharmacists, and it's upon us to take responsibility and say, we are going to make this happen. That is the first phase. And I know there are people who are keen in pediatric care, pediatric pharmacy and all that. How are you going to get into that space? I remember when I was doing my internship, that is at Kenyatta National Hospital, I had some engagements where I was working at the pediatric pharmacy level, going to the wards, talking to the patients, seeing the challenges they're having, let's say, for example, in management of children. Can you integrate that knowledge and actually apply in terms of maternal care from a obstetric gynecological perspective, getting to the pediatric support, and ensuring you're offering holistic care? Build yourself in that area. And then if you do it, we are able to deliver interventions and serve our communities better. So the willingness and adoption has to start from within us. Then once we've had that willingness and adoption, we start applying that skill in our own day-to-day interactions and documenting best practices. Once we document it, then now let's use that evidence to champion for integration into policy frameworks. And that is where we can develop, let's say, for example, best case scenarios, best cases, and these become peer-reviewed literature. Peer-reviewed literature, we develop a competency framework to nurture the next generation of professionals. We might have only 10 or 20 in the first phase. And those 10 or 20 are generating best practices, which are going to be used in developing a competency framework. That competency framework is to be used in training of the next generation of pharmacists. And upon training, we can have experiential learning, fellowships, tutorships, scholarships, whichever way we can do it, so that people are practicing and gaining the knowledge in their sets of practice. As they get that experience, they get to do it better. We now have knowledge, evidence, knowledge repository. That evidence can then now be transferred to the next level where we now shape policies. And that is where our professional associations and professional societies come into play to help drive that momentum and gain recognition and prominence on the role that we're playing in that space. And at the end of the day, we'll have grown the profession. And beyond growing the profession, we've grown and actually improved access to antenatal and maternal healthcare services. And that is the whole scope of how we need to play our role as pharmacists and how we need to envision it from a system dimension rather than from a point of care solution only. It's a point of care, yes, at the start, but as we look at it from a point of care, we need to integrate into the entire health system, leadership and governance, frameworks and policies, and then see how do we collaborate with others to make this a reality. I hope this inspires you to do something more and it helps you engage further. If you have any comments, please share them in the comment box. For now, I hope we get to engage again next Sunday. Thank you so much. Subscribe to the channel. Let's engage. Let's keep learning. Let's promote the profession of pharmacy. Thank you.